I'd like to officially start off today's webinar, Communication to Improve Patient Safety, with Dr. Arnie Mackles. Dr. Mackles has 20-plus years as a neonatologist. He's a licensed healthcare risk manager. He's currently serving on the board of directors for the Florida Society of Healthcare Risk Management and Patient Safety. He is a national CME speaker, trainer, and author. Dr. Mackles has authored a patient safety library for the Sullivan Group. There are currently 6 courses available, and he's got a 7th course on the way. We are honored to have Dr. Mackles here with us today. So, without further ado, I'd like to turn things over to your host, Dr. Arnie Mackles. Dr. Mackles, the floor is yours.
Hello, everybody, and thank you so much for joining this webinar on communication to improve patient safety. I'd like to start the program today by talking about what is often communicated to the American public about the healthcare industry. Unfortunately, the media often portrays healthcare in a negative light. And I had an experience a few years ago which truly brought this point home to me, and I call it my taxi cab story. I was taking a taxi cab from my home in Palm Beach Gardens, Florida, to the airport to fly to Columbus, Ohio to give a lecture on preventing medical errors. And the taxi cab driver was very talkative. It was about 5 o'clock in the morning, and I was half asleep, but he was talkative. So he said to me, "Are you going away on business or pleasure?" My response was, "On business." And then he said, "Well, what do you do?" And as this audience all knows, as soon as someone finds out you're in the healthcare field, you know that the medical topics and questions are going to flow. So I expected him to start talking to me about his hernia surgery or perhaps the dose of statin he takes for his high cholesterol. But instead, he looks at me directly in the rearview mirror and says, "Doc, did you see that article in Reader's Digest?" I said, "No, what article?" He said, "The one about how dangerous hospitals are." And he proceeded to tell me about this article he's just read in Reader's Digest, which talked about the danger of being in the hospital, particularly on the night shift. He said, "Doc, you know, there's a shortage of nurses, there's a shortage of aides. The nurses all float from other hospitals or agencies. They don't know the patients, they don't know the doctors, and they don't even know the other nurses they're working with. So what you really have to do," he said, and what this article tells you, is you have to bring someone with you to the hospital who knows about medicine, a doctor, a nurse, a paramedic, a therapist, someone who could sit at your bedside and protect you so they don't kill you. And this is what America is hearing. And so the first thing I did when I got to the airport, he dropped me off, is I went to the book stand, and I picked up the article, and it was in Reader's Digest. This is back a few years ago, and it was entitled "Night Shift Nightmare, How to Protect Yourself." And it was basically a primer on what you should do in the hospital. And they go through all these experiences of people having stays overnight with bad things happening. But the situation that caught my attention was a situation late at night where a patient was having a medical problem and was buzzing on the buzzer, and no one was showing up. There was no nurses around. The patient was calling out, "Nurse, nurse, nurse." No one was even passing in the hall. So in desperation, the patient picked up the bedside phone, got an outside line, and dialed 911. And the 911 dispatcher had to call the nurse's station to send someone down the hall to the patient. Now, I know this is an extreme example, but let's face it, we all know people, friends and family, who have had bad experiences in healthcare. And so our job is not only to improve our public relations, but it really is to improve the reason why we have the bad public relations. And so since that point, every time I'm in the supermarket and I pass the cashier, I look for the magazines and the covers of the magazine. And here are a couple of covers I've seen over the years. Here's one, "White Coat Confessions," in which doctors are finally admitting the mistakes they made years ago. Again, all about distrust of the healthcare system. The next one I saw about 2 years ago in Reader's Digest, 50 Secrets Surgeons Won't Tell You. Again, the media is fomenting distrust to sell these magazines. They don't say 50 things you need to know about when you have surgery, but instead it's 50 secrets they won't tell you, the bad guys. So again, we have a lot of work ahead of us, but we're on the right track. With that being said, let's move on to talking about some critical failures to communicate. Now, this is not a new problem in healthcare. We've noticed this, over the years and over the decades. But until recently, until the year 2000, really, we didn't even try to look for communication as a root cause of medical errors. You can see our little sailor man in the boat of the year 2000 searching. And the reason we're talking about that is because that was the year, as most of you know, that the Institute of Medicine came out with a report entitled "To Err is Human." And they came up with some unbelievable findings. They found there was an injury in 1 out of 25 hospitalized patients, at an estimated death rate of up to 98,000 deaths per year from medical errors, and at a cost of up to $29 billion. So from that point on, we started to really get involved, not only through agencies of the government, but through private agencies, in looking for the causes of medical errors and what we could do about them. And what we're going to see is communication has a great deal to do with causing medical errors. The Joint Commission, as you know, uses the term sentinel event, which is an unexpected occurrence involving death or serious physical or psychological injury or the risk thereof. And when the Joint Commission gets these reports that are sent in, they keep tabs of them and they review them. And if we look at the sentinel events that were reviewed between the years 2004 and 2013, there were 7,881 as of the end of year 2013. In order of frequency that they reviewed these, wrong site surgery were 13.2%, delay in treatment were 11.4% of the events, retention of a foreign body 11.1%, followed by op and post-op complication 10.1%, suicide 9.8%, patient fall 7.9%, other unanticipated events 6.4%, medication errors 5.3%, criminal events 4.2%, and perinatal death or injury 3.1%. So you can see it really runs the gamut of specialties. And when I talk to audiences of physicians and nurses, it really, everyone in the audience can have a patient with one of these events, because it's not just certain specialties. The surgeons tend to get hit the worst in these statistics, but I have a feeling that just has to do with reporting, because in the OR it's very hard not to report a mistake because so many people are involved. If we look at last year, 2013, the top event reviewed was delay in treatment, followed by wrong patient, wrong site, wrong procedure, then unintended retention of a foreign body. Number 4 was suicide, and number 5, falls. Just to show you how important communication is in causing these events, if we look at the most frequently identified root causes of sentinel events over the past 3 years, we see for 2011, 212 in the middle, and on the right, 213, communication is number 3. First, in 2011, leadership, then human factors, then communication, then assessment. The same repeats in 212, and in 213, human factors is first, followed by communication number 2, then leadership and assessment. And what is really amazing is that the part of this that has to do with the provider's knowledge and training and ability and expertise is number 4, the assessment. The others have nothing really to do with the knowledge or the skill of the provider. It's all these other factors, and communication has a lot to do with it. So we have to train our providers to communicate properly, and then we have to continue to renew this idea in them. Best way that I know is through continuing education, as well as interaction and constantly going over what needs to be done. Now, over the years, the Joint Commission, when they see a real problem, they send out an alert, and it's called a Sentinel Event Alert. About 3 or 4 times a year, they'll publish these alerts. In particular, when they have a rash of problems in one particular area, they will send out this alert telling us what to look for and then giving us some recommendations in what to do. And there have been several of these over the years concerning communication. And we just have time to go through. We'll go through 2 quick ones. The first one was from back right after the Institute of Medicine's report back in the year 2000. And it was Sentinel Event number 12, issue number 12, on operative and postoperative complications. They looked at 64 cases. 90% of the cases were non-emergent procedures, mainly elective. Yet 84% of these patients died. Now, why did this happen? The reviewers looked at it. My gosh, they thought, what could be going wrong? Did we do the wrong procedure? Did the surgeon not have skill? But when they reviewed it, what they found was 58% occurred postoperatively, and 2/3 of the hospitals identified incomplete communication among caregivers as a root cause. Communication, not the skill of the surgeon or the ability of the circulating or scrub nurse or the anesthesiologist. It was all about communication. And let's see how much we've progressed over the years. If we look at one that just came out last summer, Sentinel Event Alert number 51 on preventing and unintended retained foreign objects, we find that these errors still occur. This, as you know, is the third most frequent Sentinel event reviewed in the years 2004 through 2013, and the cost per incident is $166,000 up to $200,000 just for the medical care, not involving at all the risk factors with legal implications and malpractice cases. The recommendations made by the Joint Commission are the following. And if you think about these, they're all related to communication, not about the surgeon's ability or the scrub nurse's skill. It's all communication. We need to standardize accounting system so everyone in the organization uses the same system. We want to develop evidence-based and collaborative unintended retained foreign object policies, team briefings and debriefings before and after surgical procedures. We want to ensure that the surgeon verbally verifies the count and documents the results, as well as researching technology for better communication in this case, such as barcoding surgical instruments using radio frequency ID, as well as the traditional opaque, radio opaque materials. So again, it's all about communication. And unfortunately, our providers are not really focused on communication. We weren't taught this in medical school. We basically were taught the medicine. And I think what we have to do is constantly remind our providers how to communicate efficiently and effectively. Because preventing medical errors is not rocket science. It's the easy things we make the mistakes on. We don't pay attention or we get distracted. That's what it's all about. However, if you're involved in a legal case about miscommunication concerning the wrong patient, wrong information, be it orders, labs, results, procedures, orders that are illegible, failure to elicit critical basic information from your patient, et cetera, you might as well just write out the check because they're slam dunks for personal injury attorneys. There aren't many juries in this country that are going to stand up for a doctor or a nurse who committed a major communication error and a patient as a result was harmed. Now, the Joint Commission has come out with what's called National Patient Safety Goals, and I'm sure this audience is aware of. However, many providers are not aware of it. The first time I heard about National Patient Safety Goals was when I was putting together a lecture to give to doctors in the state of Florida for a course on preventing medical errors. I had practiced for neonatology for about 22 years and then got involved in risk management. So a few years back, I put together this course, and I found out about these National Patient Safety Goals. The fact is we need to use continuing education to update doctors on these factors because doctors are very concerned with their particular, specialty, and they read their specialty journals. But overall, they all need to know this information from the Joint Commission, and unless you signed up for these notices from the Joint Commission, you just don't hear about them. Here's one. We'll go through a few of the goals that I feel are really important for communication that we've seen over the years. As you know, there's like 10 or 12 goals that they tweak from year to year. They change some, they add some, and delete some. We need to use two patient identifiers when we obtain blood, give meds, do procedures, or treatments. And what's really important, they added it a couple of years ago to this goal, was label and presence of the patient. Now, not only does this serve as a double check to make sure, you have another person checking it, but it's really great for patient satisfaction because the patient is involved. The patient walks away saying, my doctor cared so much about me and the nurse cared so much about me, they wanted me to make sure it was me, my name on the label. And it really goes a long way to increasing patient not only responsibility, but participation. Again, to improve the effectiveness of communication among caregivers, we want to read back phone and verbal orders and read back test results. Now, I'm not so sure how much this is actually happening. I know before I stopped practicing to do risk management full time, I would give verbal orders all the time in the newborn nursery or on the phone, and nurses would never read them back to me. Yet when I went to the record room to sign my charts, there it was in big letters, VORB, Dr. Mackles, verbal order, read back Dr. Mackles, and it never happened. As far as I'm concerned, it was more of a CYA than a VORB. And what's interesting is the Joint Commission in 2011 published information on this, and they looked for compliance on this particular goal of reading back phone and verbal orders. And they said 98% of hospitals in America that they surveyed were compliant with this goal. And when I go around the country speaking to doctors, I always say to the audience, you know, the Joint Commission felt there was 98% compliance. How many of you can say that 98% of the time you give a verbal order, it's read back to you? And I rarely see a hand pop up, and I've seen, you know, talked to thousands and thousands of doctors. So what it is, it's a workaround. The nurses know that the charts are going to be ordered, so they make sure that's in the chart. And they work around the fact that they need for safety to read them back, because it's so easy to make mistakes when we're giving verbal orders, especially over the phone with cell phones. We need to measure and improve reporting time of results, because we saw that delay in treatment was the #1 sentinel event reviewed in 2013. And standardized communication handoffs, because handoffs are prime time for communication errors to occur. Now, this goal people may not think is that important, but I had some personal experience that showing it how important it is. We want to label all medications, medication containers, and other solutions on and off the sterile field in perioperative and other procedural settings. You want to label on and off the sterile field all syringes, cups, and basins, as well as transferred solutions with the name of the medication, strength, quantity, diluent volume, expiration dates, and then verify it verbally and visually. I worked in a hospital here in Florida, Martin Memorial Hospital, and back many years ago, there was a famous case of Ben Kolb. Ben was a 7-year-old boy who went in for elective ear surgery. And unfortunately, during the surgery, he had a cardiac arrest, and they worked on him for an hour or an hour and a half, and he left the operating room in a coma and died a few days later. The reason this happened after they evaluated it is they were preparing 2 solutions for the sterile field. One was adrenaline 1 to 1,000 concentration, and the other was epinephrine 1 to 100,000. One solution was going to be used to dab bleeders, and the other one was to be injected around the site. Unfortunately, the basins were mixed up because they weren't labeled, and they were injecting the concentrated solution, and that's what caused the cardiac arrest and the problems. The only good news that came out of this is Martin Memorial Hospital actually attended to it right away, evaluated the situation, called in experts, had everything tested, and then reported to the parents. And they were actually written up by the Joint Commission as a correct way to deal with the family and deal with the problem. So some good news has come out of a bad situation, and this is very, very important. It's often overlooked. The next goal is to report critical results of tests and diagnostic procedures on a timely basis. We need to develop procedures for reporting results with a definition of the test or procedure, who to report it to, acceptable time for results coming back, and then how do we manage the results of the critical tests. And then we have to measure the timeliness. And as I said before, delay in treatment is a major, major problem now, and this has a lot to do with it. So we really need to become efficient in getting results reported and then action taken when necessary. Here's a favorite topic of mine, healthcare handoffs. They're key moments in patient care. As a matter of fact, last year we put together a course on handoffs, transitions, and discharges because this is such an important aspect of medical care, and this is where you make mistakes. Handoffs can be fumbled. They can be fumbled on the football field as well as in the hospital. And I always like to use analogies and stories in my lectures and in my courses for the Sullivan Group. So we're going to quickly talk about a famous fumble that happened on the football field. There was a famous game between the Philadelphia Eagles and the New York Giants that occurred back in 1978, if any of you football fans remember that, at the Meadowlands Stadium in New Jersey. And during this game, the Giants got a quick lead, and they were way ahead. And slowly, as the game progressed, the Eagles caught up, so much so that with only seconds left to play, the Eagles were fairly close. With 31 seconds to play, the score was Eagles 12, Giants 17. So all the Eagles really had to do was score a touchdown, and they would win. However, the Giants had the ball. So they had the ball with 31 seconds left. The entire stadium just assumed that the quarterback would just hold on to the ball and the Giants would win, okay? That's what everyone assumed. Unfortunately, they weren't all on the same page. So if the quarterback, Joe Pisarcek, could only hold on to the ball for the final seconds, Giants would win 17-12. But instead, Pisarcek attempted to hand off the ball to running back Larry Zonka, who wasn't expecting it. Nobody in the stadium was expecting him to hand it off. The ball awkwardly hit Zonka's leg and was fumbled. The football was picked up by Eagles defensive back Herman Edwards. Some of you may know Herman Edwards because he's an ESPN football commentator now. So he sees the ball, he picks it up and runs it 26 yards back for a touchdown, and the Eagles win 19-17. Why? Because the team wasn't on the same page. They did not communicate properly in the huddle. So the elated Eagles fans call this the miracle at the Meadowlands. Unfortunately, the dejected Giants fans simply refer to it this day as the fumble, and it's a famous event. Why? Because everyone wasn't communicating. And it's all about communication, whether it's on the football field or in a huddle before a procedure in the hospital. That's what it's all about. Unfortunately, there are many barriers to successful handoffs. Physical settings are often noisy with poor lighting. You can be in a busy unit. Privacy concerns now with HIPAA, you don't want to speak too loudly for other people being around. Then we have no face-to-face interaction, especially with cell phone connections. You know, can you hear me? Can you hear me now? Then interruptions. Phone calls, lab reports, emergencies, and other issues. I worked in a neonatal unit with about 40 or 50 babies, so it would take us a good hour to make rounds in the morning. And I can't even remember a time on rounds when we weren't interrupted for some reason, either an emergency or a phone call or a lab result or a baby crashing. So it's very difficult to do these without interruptions. Then we have inconsistencies. There are differences in styles of reporting. Doctors tend to talk in headlines or bullets, boom, 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 when nurses were trained to be very descriptive about the patient's condition. And the difference in these styles can lead to misunderstanding. Then we have fatigue and stress, which always is present in the hospital, whether you're coming on a shift or leaving a shift. That can always be a barrier. So we've had many methods over the years that have been used to improve handoffs. Most of them come from the military. The most frequently used one that I'm sure most of you know about is SBAR, which was used in nuclear submarines and adapted for healthcare use by Dr. Leonard of Kaiser Permanente. And it can be tailored for various types of handoffs. It's a handoff sheet in which there's SBAR written, and it's filled out on the worksheet and then discussed from the sender to the receiver of the patient or the information. S, situation, what's going on with the patient. B, background, what's the clinical background or context. A, assessment, what do I think the problem is. And R, recommendation, what would I do to correct it. Now, I feel that we're actually going to the next generation of methods to communicate at handoffs. And I think the next generation will integrate the computer successfully. And one place that's already done it is Boston Children's Hospital. They use the iPass system, and it was developed to improve how sender and the receiver of care, and then it's passed on after this discussion. And they did a before and after study, and we'll go through that in a minute. First, I just want to explain what the iPass is. I is for illness severity, P for patient summary, A for action list for the next team, S for situation awareness and contingency plans, and S for synthesis and readback. They did a 3-month before and after pilot study. After implementation of iPass, there was a 40% reduction in medical errors, going from 32% down to 19%. And as an aside, they found that more time was spent with the patients, 225 minutes per 24 hours versus 122 minutes. The next slide very much impresses me. We can get it here. After implementation of iPass, the inclusion of a patient to-do list went from 29% way up to 82%. And inclusion of the all-important medication list went from 3% to 100%. Now, these jumps up to such high levels were not because suddenly the residents became smarter or had better memories. It was the computer. So the perfect way to go forward for our patient's sake and for the sake of the care is to include the computer, because the computer remembers these things that we tend to forget or don't consider that urgent. Moving on, let's talk about the universal protocol. Although it's not currently a patient safety goal, it is included on the website of the Joint Commission with the patient safety goals. And we all know there's a pre-op verification process where we mark the site and there's a timeout before starting. And unfortunately, around the country, although most places say they do the use the universal protocol, we still see a lot of wrong site surgery occurring. The next goal came out a few years ago, but I feel it's really important. The goal was to encourage patients' active involvement in their own care as a patient safety strategy by providing a means for patients and families to report concerns about safety. Very often the Joint Commission has seen medical disasters occur when in fact the patients or their good friends or families saw bad things happening and either spoke up but weren't getting the right responses, or did not speak up because they just assumed that, you know, the doctors and the nurses knew all about this problem. So this led to rapid response teams. Here's one from the University of Pittsburgh Medical Center that is made up of a house physician, a nursing supervisor, and a patient relations representative. And if any patient in the hospital, they're told when they're admitted that if anything happens where they don't understand the care or they see bad things happen, they need to dial a certain number, and within 10 or 15 minutes, just like a code, they'll get a team arrive to try to figure out, is there a real problem going on here? If there's no problem, that's fine. But very often they'll find the beginnings of a problem that, if isn't dealt with, can cascade out of control and lead to a medical disaster. Now let's talk for a few minutes about ensuring safe and efficient discharges by communicating, because that's when we have so many problems due to lack of communications. Patients go home and they don't understand their care, they don't understand what they have to do. So the idea is to get the patient from the hospital to home without going back to the hospital, especially now because due to healthcare reform, there are already 3 diagnoses that if you have an excessive amount of 30-day readmissions, your hospital will be penalized financially. And starting in 2015, 3 additional diagnoses will be added. And the feeling by hospital watchers is that eventually there are going to be a whole long list of these conditions that will have penalties for excessive 30-day readmissions. So to respond to this, many hospitals are instituting transition of care models, which are basically interdisciplinary teams that coordinate the care of a patient throughout, from admission through the different places in the hospital to discharge and post-discharge. And they present a summary to the patient in the patient's language at discharge, and they coordinate the discharge with before they leave, and then even after the patient leaves the hospital, they have phone calls, they have visits, and they check up on the patient to make sure that they actually went for their after hospital visits. And then they survey the patient to see what the quality of their understanding of their own condition was, as well as the discharge instructions. And we're going to end our program today with some slides that are very important for providers to know about. These are simple strategies to improve provider-patient communication and compliance. And we go through this in the courses that we have in the Patient Safety Library and the core curriculum at the Sullivan Group with our online courses. And these are basic, simple features that if we can get our providers to understand them and educate them and practice it, eventually they become part of their daily practice. So first, what they need to do is before they go into a room, the provider needs to review the chart, because first impressions really count, and patients don't want to see the top of the provider's head buried in the chart as you walk into the room, you know. That's not a great first impression. You always want to start with a warm introduction and greet the patient by name, formally if you don't know them. If you want to have a less of a formal basis, instead of saying, you can say, hello, Mrs. Jones, you know, I'm Dr. So-and-so. You can always say, may I call you Molly? Or, you know, how would you like me to call you? Ask permission for that. Then you always want to make eye contact. Every time you're dealing with a patient, you want to make eye contact, because if you're not looking at a patient, they think your thoughts are elsewhere. And this was one of the problems I had that I didn't even understand early in my practice. When I'm involved with a patient's condition, I tend to think about it and try to find an answer, and I'll, you know, gaze up at the sky or down at the floor, and that's just the wrong way to do it, because the patients are there for you to think about them. And so really make eye contact. It'll help a lot with your relationship. Now remember, patients may be anxious. Perfect example were my parents, my mom. My parents both lived to the ripe old age of 93. They died a few years ago, but over the years, my mom was super, super anxious about health care. And anytime she got anywhere near a doctor or a hospital, her blood pressure would shoot up, and she'd get so anxious she didn't remember anything. So she would drag my dad with her to the hospital visits or to the doctor's visit. And then when she got home, she'd say, Dave, what did the doctor say? Because she remembered nothing about it. So keep this in mind. And if you do have patients that may be anxious or concerned, make sure there's someone else with them or someone you can call to talk about the case. Here's a really important one. If you can, take a seat after entering the room. They did a study where a doctor walked into a room and stayed a certain period of minutes in the room. Then the doctor left. Another doctor came in, stayed the exact same amount of time, but pulled up a chair and sat. And afterwards, when they queried the patient on which doctor spent more time, the majority of the patients thought the doctor who sat down spent more time with them. Now, we're not here to trick our patients, and I'm not telling you this to trick your patients, but whatever we can do to create an atmosphere that the patient is comfortable, we can have a give and take, and we can get more information, and they can really process what we're saying. So this is what it's all about. So these techniques are really important for providers to understand and to practice. We want to face the patient and listen to the patient's concerns and acknowledge. Try not to interrupt if possible. However, I know we all have patients that if we don't interrupt them, we'll be there for 2 hours listening to everything under the sun. But if you can avoid interrupting, do so. In order to confirm patient understanding, we don't want to simply ask a patient if he or she understands the instructions, because most people will just say yes and nod. again, this is something when I was in my early years in neonatology, I'd be speaking to these really distraught parents with these sick, critically ill babies, and I, thought I was pretty good at explaining things. I would draw pictures and explain things, and then I would say, "Do you understand?" And they would most of the time nod yes. Now I look back and I say to myself, how much of it just went way over their head? So we constantly have to think about this, and we want to confirm understanding by getting them to teach it back to us. The teach back technique is really just ask the patient to explain it back to you or teach it back to you. If you feel that the patient might be threatened, you could do it, you can finesse it by saying, "Mrs. Jones, when you go home tonight to your husband, how are you going to explain to him what medications you have to take and how often?" So there are ways of doing it to bring the patient into the conversation, and really this is the only way we will know if they understand it. So again, this word has to get out to our providers, and it has to become so familiar to the providers that they use it in everyday practice. We want to focus on the patient and don't talk too much about yourself. Again, something that I wish I knew this information 30 years ago when I started practicing because I really could have used it. Again, with my neonatal parents, if they were really nervous and I knew them a little bit, I'd talk to them for a couple of different times, I would try to break the ice with them. I would talk about what I did for the weekend or my ski vacation, thinking that would break the ice and put them more at ease, but I was so wrong. That didn't help. They don't want to hear about my weekend. They want to hear about their baby. That's where their focus is. So don't talk too much about yourself. And unfortunately, now we know these things, so it's important to get this word out to our providers. We need to provide patients with written instructions. Again, I've had experience myself just recently this summer. My son broke his collarbone earlier in the summer playing basketball, and he needed to have surgery to have a pin inserted. And surgery goes fine. We're in the recovery room. He's pretty sort of awake, and the surgeon comes over and starts, explaining everything to me and telling me what we have to do afterwards and how I should dress the wound and when the stitches come out. And here I am, a physician for all these years. I get home, and thank God I had those written instructions because I was like, I didn't hear a lot of what he said. So it's very important to give written instructions. We're going to end with bows and arrows. Here's a little anecdote of an experience I had early on in my training when I was a pediatric resident. And it taught me a lot about how important it is for us to understand our patients and them to understand us. I was working in an large outpatient pediatric clinic in New York City, and the way the clinic was set up, you go from room to room, and the patients were already in the room. And outside of the room was a little, box with a chart. So I went to this room, and I pick up the chart, and I start reading the chart, and I hear crying, bawling, crying going on from inside the room. So I, looked at the chart quickly, and I walked in the room, and I see a mom and a dad sitting there, and a little 4-year-old boy whose head is in his mom's lap crying hysterically. He's crying and sobbing and sputtering. So I go into the room, and I get down on the knee right up to him, and I say, "Hey, what's the problem?" And he turns around with these red eyes and tears going down his face and sputtering, and he said the following: "I don't want a bow and arrow." And instantly, I understood him. I said, "Fine, that's okay. It's okay with me." And slowly he stopped crying and stopped sputtering, and we went on with the exam. He composed himself, and we went on with the exam. Now, this was not a typical outpatient clinic. This was the outpatient oncology clinic at Sloan Kettering Memorial Cancer Hospital in New York City. And this was not a typical 4-year-old boy. This 4-year-old had acute lymphoblastic leukemia in remission. And he was not talking about a bow and arrow. He was talking about a bone marrow. And fortunately, I had been in the clinic a while, and I understood, the terms and the lingo that the little kids used. So I understood him, and he understood me. But then it made me think: did the parents really understand everything going on with their son? Did we explain everything to them? If they had to rate patient satisfaction, how would we have done? So it made me realize that going forward in healthcare, whatever we can do to communicate better with our patients, make them feel at ease so we can get the important information from them, whether it's drawing pictures or using models or showing them videos, or just spending more time and talking to them and getting the feedback if they understand or not, through confirming understanding. And if we use these techniques and we get our providers to learn these techniques, I feel we'll have a lot safer future and a healthier America. Thank you so much.
Dr. Mackles, thank you so much for providing us with such a fantastic overview of the impact communication has on patient safety.